All right, well, we're running a couple minutes late, so we'll move along because I know many of you probably have planes to catch. I know I do, 3:30, so we got to get through this in a question and answer session. Okay, get my pointer in case I need it at some point. So we're going to talk about using laryngeal mask airways. I think when Callie gave me the topic, as many of the speakers have said at this meeting, I knew nothing about the topic I was supposed to talk about. That's not quite true, obviously. I know what an LMA is. And the title of the talk was Supraglottic Airways and C-section. But I'm going to bet that if you're going to use a supraglottic airway, it's going to be an LMA. So I changed the title a little bit. And the question is the use of an LMA dangerous heresy or a reasonable option? So these are my disclosures. As I told you, obviously, if you use an LMA and it's malpractice, this could be a conflict. That's not really going to be my conclusion. Theoretically, maybe some of the use of LMA at C-sections is an unindicated use. So maybe that's a disclosure too. I'm not really sure if that's necessary. Okay, so we'll skip the objectives. You have that in your handout. I'm going to show you two cases right now, and then in 28 minutes or so, I hope, we will reach some kind of conclusion about whether LMA use is appropriate and whether what was done was appropriate. So this was a case of G2P1, previous C-section, undergoing TOLAC, which did not result in a successful VVAC. She was in early labor, suddenly had severe abdominal pain. There was actually some suspicion of uterine rupture. She was taken to the OR fairly quickly. This was not super urgent. She wasn't hypotensive. The fetal heart rate was still okay, but it was concerning. They were worried that this didn't quite look right. Induced anesthesia, and my colleague in my group could not open her mouth, and it's a pretty experienced anesthesiologist, and she told me this was weird. This looked like, Masseter spasm to succinyl choline. It was quite unusual, and it didn't get better in 30, 45, 60 seconds. They were able to ventilate a little by mask, weren't happy with it, sort of shoved an LMA through the teeth and into the back of the throat, and actually it settled in a way that looked quite good. And they had an airway, patient oxygenated fine, chest is moving, a little positive pressure, no problem. So the question was, what do you do next? Okay, we'll leave that for now. That's a really good case. We could spend a half hour on that case. We won't. Another one was a G1P0, straightforward, for C-section, had major back surgery, I think 3 separate hardware placements and 1 infection and another replacement. And we told her we would have been willing to try to do a regional, but she really didn't want us touching her back. And we thought this was completely reasonable if that's what she wanted. And the plan was to put her to sleep. Uneventful induction, but difficult. Inductions are always uneventful, aren't they? It's just a matter of if the IV is working. I love that. Smooth induction. Yeah. Anyway, not quite. 3 laryngoscopies, 2 intubation attempts by experienced people. Well, probably the first one was the resident. SpO2 drops to 86. They place an LMA. SpO2 comes up to 100. The LMA is seating fine. They're able to give positive pressure ventilation with a leak at about 18 or 20. Patient's now breathing spontaneously. And this is an elective section. What should they do? Wake her up, get the baby out. That's the decision point. So we all know that what we worry about in this context is aspiration. Because let's be clear, the problem is not oxygenation in those 2 cases. We have an airway, patient's oxygenated, she's breathing. The only reason, I think, to not do every single C-section with an LMA is we worry about aspiration. I don't have time to talk about the whole history of this aspiration issue, controversy, nonsense, important issue, whatever you want to call it. It's a great talk that I've heard a couple people give. But we know it's an obstetric hazard, as this title from 1940 says. As Joy Hawkins' classic paper in the 90s talked about the risks of general anesthesia, we assumed those risks had to do with aspiration and things like that, or perhaps more failed intubation. But that being said, every OB textbook's written since the beginning of time, since 1940, said that the patient must be intubated with a cuffed endotracheal tube after rapid sequence induction of cricoid pressure. So that's what the textbooks say. And we know the textbooks are always right. And this, my least favorite comment in medicine, at least that I ever come across, pregnant women are full stomachs. Now, first of all, pregnant women are a lot of things, and they may have full stomachs, but they are not full stomachs. There should not be an equal sign there, and all of my residents, at least once on their first OB rotation or on their mock oral exam, say this. And I don't like it. Doesn't matter that I don't like it. You shouldn't like it either, though. Okay. Interestingly, not interestingly, if you're interested in this topic and want to get a sense of what people were talking about when it first became a real issue, this is a really nice review. Early 50s, I think 51. Robert Hinkson also is a great person. If you want to read a biography of a fantastic anesthesiologist, take a look at this. Not this, take a look at his biography. But this was a classic article about the incidence of aspiration vomitus in the early 1950s across the United States. And when you read some of these cases, it actually makes us feel better, I think, about what we do now. Because one of the cases, I just read the whole paper last night, but one case involved a woman having a vaginal delivery for twins, and she went back for the delivery of twins, and they gave her, I'm not kidding, 500 milligrams of thiopental to aid in the forceps delivery of the first twin. And they commented that she was still lightly anesthetized. 500 milligrams of thiopental, that's pretty deep for a vaginal delivery. And at some point during the delivery of the second twin, after they gave more anesthesia of some sort, I think ether or something like that, she did vomit and actually didn't do well. But after 500 of thiopental and ether and messing around with forceps on 2 different babies, that may not have been the best management, at least by, say, 2014 standards. So we do worry about aspiration, but we know that most aspiration deaths occurred historically during face mask anesthesia or once an intubation was attempted and failed, not spontaneously during induction or during, in most cases, rarely during LMAs, frankly. There were no intubation or aspiration deaths in a large series that Jill Meyer published from Michigan, which you probably are at least vaguely familiar with. This was 15, 18 years in Michigan, all anesthetic deaths. There were no aspirations that caused death. And the only general anesthetic deaths, really, and the only airway deaths happened in the recovery room or from a high spinal. There weren't that many. LMA is, of course, in the ASA algorithm now, so we know how to use it. I think most of us do. We kind of know when. And in the 1990s and 2000s, there have, of course, been multiple case reports of the use of LMAs and C-sections, mostly for rescue. And I think you sort of know this. Probably most of you have either heard of one in your institution or used it yourself. This is just some of the case reports. I think I put this slide in the syllabus. So, LMA is in the algorithm somewhere down here, not somewhere, right here. And it's basically when intubation fails and then you can't ventilate by mask. And what you're supposed to do once the LMA is in, well, actually, I was going to suggest that it's possible we should be going right from failed intubation there without even trying bag mask, but that's a judgment call, I think. The question is, once the LMA is in a rescue situation, and I'm assuming most people here wouldn't have much question. If you can't intubate, pregnant woman, having a little trouble with bag mask ventilation, or even you don't even want to try, that most people, in order to prevent hypoxemia, would put an LMA in. I'm assuming that. That may be a wrong assumption. But here are the issues. Should it be used at all? I actually think that would be a difficult case to make. If you can't oxygenate the patient, you should put something in to help, whether it's an oral airway or an LMA. And with our experience, probably an LMA is better, but something like that obviously has to be done. Should it ever be used electively? Should you just decide, you know what, I'm going to do my next C-section with an LMA, not a tube? We'll see. If it's used and it's in because you had trouble with the intubation, should you proceed with an urgent C-section? If it's used and it's in, should you proceed with an elective C-section? If it's in and it's used, should you take a fiber optic out and get the tube in through the LMA? I'm not going to be able to answer all these questions. I have 16 minutes and 12 seconds left. What kind of LMA should you use? And finally, where should it be on the difficult airway algorithm? These are some of the questions. I'll try to talk about some of them. Interesting, and one more historical thing. I really like history, and it means I don't have to think of new things. This is actually the first time anyone pointed out that pregnant women might be more difficult to intubate than non-pregnant. We think everyone knew this forever, and it's, obviously we're so smart, we would know it even if no one told us, right? But in fact, it wasn't until the late 90s that Gertie Marks, one of our great obstetric anesthesiologists, and Mike Finster, who was my predecessor at Columbia, also a great obstetric anesthesiologist, were doing some work for New York City and found that there were actually a surprising number of dead pregnant women from general anesthesia C-section, and the story was they couldn't be intubated. And This had not been appreciated before the late 70s. I didn't know this till Mike, when we had lunch 2 weeks ago, said, do you know that Gertie and I published a paper about that? So let me show you a few series of what happens when you can't intubate and how LMAs are being used worldwide. This is a series from Australia and New Zealand. They looked at 50,000 C-sections with a general anesthetic rate of 2 to 3%. So this is, the kind of Western practice. We don't like to do general anesthesia. Most centers have general anesthesia rates in that sort of 2 to 5, maybe 10% if you happen to be on the south side of Chicago, as Barbara said. They had 4 failed intubations in 1,086 general anesthetics. Now, that's about 1 in 250. It's uncanny how often that number comes up. The failed intubation rate in obstetrics in almost every large study is somewhere between 1 in 200 and 1 in 300. So I don't know if there are any residents here, probably not, but if you ever take the boards and need a number or you're asked a question, that really is the number. It comes out all the time. And a couple other studies seems to be around there. So about 1 in 250 times, can't get the damn tube in. What did these people do with those 4 cases? Well, all 4 of them, all 4 failed intubations, got managed with LMAs. So that's 100%. It's only 4 cases, but it's 100% of the time that's what they did. 3 of them were viewed as emergencies. We don't have information on how emergent. They left the LMA, did the case, everything went fine. 1 was elective, and they awoke the patient apparently after trying to intubate through the LMA that didn't work well, so they just woke her up and did something else. They also commented in this article from Australia that that the LMA seemed appropriate because well-selected patients are sometimes managed with LMAs in Australasia. And we'll show you a couple of large series. So that means that what these authors are saying is that, in fact, sometimes they just use LMAs for these cases anyway. Another series from Britain, 2-year study of 57 failed intubations. So this is just going to the failed intubations. 80% of them tried some kind of LMA or other supraglottic device, and 8 of them proceeded in non-urgent cases with the LMA. And so, anyway, so you get, I don't know how many of these cases were non-urgent, but 8 of these cases, which were viewed as non-urgent, they proceeded with the case. Let's talk about 3 large series. This came from South Korea in the early 2000s. 1,067 patients, more or less consecutive with the selection they used. Anyone with a BMI over 30 wasn't included. That would be 90%. No, it would not actually be 90% of our patients. We would say that. We've looked at our numbers in the last 5 years. Our average BMI is 28.2. And so patients aren't quite as big as we sometimes say. Now, I did present a patient with a BMI of 100 last year that I took care of. That's pretty big. There's 7 anesthesiologists in this series, all with a good amount of experience. And basically, they did 1,047 cases, and 98% of the time, the LMA went in on the first attempt. 2% had a little bit of an air leak or obstruction. They intubated a little less than 1% of their patients. And essentially, in 1,000 cases, everything went okay. Doesn't prove it's going to be right in 1,000,000 cases, but the truth is, 1,000 cases without any significant problems tells us something. What it tells us we can discuss, but it clearly means something. And here's, I guess, what I thought it meant. At the very least, the LMA is okay for rescue. I mean, if you can do 1,000 consecutive elective cases, then I think the question of whether you should ever try it when you're in trouble goes away, okay? And maybe you could consider it for elective cases. I don't know, the opera singer who's very thin and understands the risk and doesn't want a tube through her cords. And the BMI restriction, who knows if it was needed, but they did do it. Now, here's another series. This series is from Amman, Jordan. The reason the studies are done in these places is these are places that do a lot of general anesthesia. We couldn't do a study like this at our place. We do, 45, 50 general anesthetics a year, maybe. But they took 3,000 elective C-sections under general anesthesia, and I guess there's nothing special on this slide. Basically, they're straightforward cases. They used a ProSeal LMA. That's one of those ones where you can have a port that you can suction down the esophagus. And in fact, they inserted these with a OG tube, I guess you'd call it, through that port already. So when they put it in, they essentially had a gastric drain in. Whether that's needed or not isn't clear, but it's not a preposterous idea if you're worried about gastric contents. So what they did is they inserted this ProSeal LMA. They released cricoid pressure to seat the LMA. It appears they maintained cricoid pressure through most of the case after that, so that takes an extra person. I'm not sure that's a great idea or necessary. But in any case, they had successful placement in almost all these cases. This was the definition of successful placement. Had to happen in 3 minutes. They had to have a square wave capnogram. They had to have adequate chest movement, and the expired volume had to be reasonable. They actually checked fairly in some detail for regurgitation by measuring the pH in the mouth and in the underside, the bowl, if you will, of the LMA, which is more than we ever do in patients who we intubate, of course. And if we did that, we'd find some pHs low in the mouth and the pharynx, as we know. So what did they find? Well, 2,992 out of 3,000 went absolutely perfectly. Again, I don't know whether to believe numbers like this all the time, but most of them obviously went pretty well. 8 required a larger LMA, and they all went up fine when they did. No one required intubation, and they found 1 pH less than 4 in someone's mouth with no clinical sequelae. So this is 3,000 cases without much trouble. One last study from another place that does a lot of general anesthetics, and that's the reason these studies are coming there. I'll go through it quickly because it's the same sort of result. They also used an LMA with a gastric, esophageal port, essentially. 700 cases, same sort of exclusions, although they used women up to a BMI of 35. They excluded Mallampati 4s. I guess the idea was, if someone's Mallampati 4, they don't want to be screwing around with trying to intubate if the LMA doesn't work. Their outcome, again, they did measure the pH in the bowl of the LMA, and their results were very, very similar. About a 2% problem in putting the LMA in on the first attempt, but they all went in on the second. Maybe they changed size. That wasn't entirely clear. They did aspirate gastric fluid and got the usual amount of fluid. Their C-sections took 31 minutes, so I'm moving to China next week. And there were no incidences of aspiration or regurgitation. So, Ashraf Habib from Duke wrote an editorial that I don't completely agree with, but some of these points are undisputable. He basically said just what I said about general anesthesia, but basically we now have 4,693 patients in 3 series, all of whom did well. It means that LMAs, and he said that probably these LMAs with gastric drains are preferred over the standard LMA. I don't think we really know that, but it kind of makes sense. It looks good on paper, I guess. He certainly agrees that earlier use when you're having an airway problem is appropriate, and it should be the first thing you grab, and you shouldn't have too much hesitation that it's a bad thing. It might even be a situation where you grab it before your second intubation attempt or before your bag mask ventilation attempt. I think you can make a strong case for that based on these series and what people are doing around the world. Dr. Habib didn't make any comments on what to do once it's in. And here's the question. What do you do once you put the LMA in? And again, in most cases, this is going to be after failed intubation, I'm assuming. I'm not sure in 10 years we won't be using LMAs on some elective cases. It could happen, but it's not going to happen tomorrow in the United States. I think we all know that. The traditional advice is to wake her up unless it's a true emergency, and maybe only if it's a maternal emergency, and sacrifice the baby because we can't put mom at risk. That is the usual advice. It sounds very good. It sounds incredibly ethical. I have 6 minutes left. We're not going to be able to debate this completely here. I think it's the wrong advice most of the time. I do. Because, and again, you can imagine your own cases, but if you've had trouble intubating someone and now you have an LMA in that is working well, I would submit that it may very well be the right thing to do the operation. Because if you don't, in a even an elective case, you've got to do something to get her airway secured next time, whether it's in an hour or tomorrow. And that's not the lowest risk thing. This is someone who can't be intubated. So it's going to be a fiber optic, it's going to be doing a regional in someone you didn't want to do a regional in before for some reason. It's not a clear path. And you have an airway that's established. And this is not what the talk's about, but I think we all sort of know now that the stated risk of aspiration, or the perceived risk of aspiration, is not as high as we've sometimes been told. And it's probably not all that high once you have an established airway with a halfway decent seal. I understand bad things can happen, but I would just suggest that in many cases, proceeding could be the right decision because the airway has to be secured somehow. An in-place LMA may be safer than doing additional procedures to secure a difficult airway. I'm not talking about the LMA that's not quite working right with a lousy CO2 curve and oxygenation in the 80s. Fetal urgency, is almost certainly a reason to continue. I am not interested in waking mom up, telling her I saved her life because she had a moderately difficult airway, but her baby's dead. No one is going to thank you for that. It's not even right. Women don't get pregnant to be safe. They get pregnant to have babies. That's not really how we always think, but it's important to think about the reality of the situation. How secure is the airway? How likely is it you're going to have a serious problem? If you have an aspiration, to be frank, how likely is it she's going to have a serious complication from the aspiration? Depends how bad the aspiration is, but again, I'm throwing out ideas with 4 minutes to go. It's not quite fair. Most cases, in fact, where there's a failed intubation, I would submit, do have some degree of urgency, because the number of times we take a patient for a purely elective C-section and fail to intubate is very small, because we assess these airways and we have other devices, et cetera, and we're ready for it. So the number of times you go for an elective section and can't intubate is really small. So which one to use? Nobody knows. There's obviously no studies. I think I do sort of agree it might be a nice idea to use something with a gastric drain. Again, it looks good in the obstetric anesthesia record that we did something to get the stomach contents gone. So let's go back to my 2 cases. This is the interesting one with masseter spasm on a fairly urgent section. There's actually a suspicion of uterine rupture. This has all kinds of interesting issues. This woman may well have malignant hyperthermia. I'll jump ahead and tell you her CPK level 2 days later was 14,000. So she probably did have something a lot like malignant hyperthermia. But at the time, they weren't sure. You always wonder about masseter spasm. Have you just not waited long enough for the sucks? Is it just something else? But my colleague thought it was masseter spasm, got the LMA in, decided this was pretty urgent. The LMA was seated perfectly fine and told the obstetrician to proceed. They did a combination of a little bit of positive pressure ventilation, got the patient breathing spontaneously, let her breathe spontaneously, which seemed to be working, told the obstetrician, and I think this is good advice, don't jump on the belly too much, don't push the uterus too much if you can help it. Sometimes they can't, let's be fair about that too. But she did say, look, we don't have a tube in, we have something else, we think we can proceed, but be as gentle as you can. What she did do, which probably shouldn't have been done, this case will be presented at SOAP, I think, is they used sevoflurane for the anesthetic. I think I would have switched to propofol or something like that, because they did really suspect malignant hyperthermia, so that probably wasn't the best thing to do. CO2 levels did not go up. Patient did not get any further symptoms of MH except for the CK level the next 2 days later, I think. So they proceeded, did the case, urgent section with an LMA. I think it was right. I know yesterday I talked about negligence. I would have defended almost any decision in this. These are the kind of cases where you have to make a decision, and we could argue reasonable people might differ. I think here, where you went to the OR suspecting uterine rupture, it's not a really hard decision to go ahead here. If the LMA was questionable, you might go ahead anyway. I mean, it's not clear what you do. The other case was a really purely elective case. Remember, she's having surgery because her back is no good. She's having general anesthesia because her back is no good, or doesn't want us to put anything in her back. So we have what we think is a perfectly seated LMA, and I think 10 years ago, I would have said, and most of you would have said, no, you got to wake her up and you'll do a fiber optic, or you'll talk her into trying a spinal with all the Harrington rods she has, or you'll do an awake something or other intubation with a glide scope, or whatever your strategy is for the known difficult intubation, or you'll go on vacation and tell your colleague to do the case. That's a good strategy too. In fact, what my colleague did here is, on an purely elective case, proceed with the case. And the logic, as I tried to allude to before, and perhaps I went too quickly through my thinking, is no matter what you do, if you wake her up and take the LMA out, and in fact, when you take the LMA out, it might be the highest risk of aspiration, I suppose, as she's emerging. But you're going to have to go back at some point, probably later today, and figure something else about her airway. And frankly, fiber optic intubations are not without aspiration risk. It might actually be higher aspiration risk than a well-placed LMA with a spontaneous ventilated patient or an easily ventilated patient at low pressures. So they proceeded on both these cases. We could certainly disagree about it, but I think it was not particularly unreasonable. So in summary, this has been said over and over, but even more in the last 10 years, I think we're starting to learn what to be crazy about and what not to be crazy about. Hypoxemia is much more likely to kill you than aspiration. So if you have an oxygenated patient, you are probably doing okay by that patient. I don't like to say you're not in trouble, because you're never in trouble. It's the patient who's in trouble in these situations. Anything that maintains an airway is better than something that doesn't, okay? I think you should use an LMA early in your dealing with a difficult intubation, maybe earlier than I might have 10 years ago. And I actually kind of think that you should continue the C-section if the airway, if the LMA seems to you to be seated well. If there's really any indication of urgency, because it's going to be a while with a bunch of things that have to happen again before you can reestablish this airway another way. Or if you think an alternative airway or alternative strategy may be actually more problematic than just leaving the damn thing in that's there and working already. And maybe you should ask the surgeons to limit abdominal pressure, tell them what you're doing, and maybe have the real surgeon do the case, not the first year resident, so you're done in half an hour. And that means I'm done. That's just my dog, and I miss her, so I wanted her to be my last slide.